Welcome to our micro lecture on urinary incontinence, covering the American Geriatric Society 5 M's under multi-complexity, competency number 22. Dr. Delage has a 2% FTE with the GWEP grant through Dakota Geriatrics. These micro lectures were developed with assistance from artificial intelligence ChatGPT. Urinary incontinence falls under the geriatric 5 M's in multi-complexity. This is competency number 22. Urinary incontinence is common, underreported, and significantly affects quality of life. Prevalence varies by age and sex, but affects up to 50% of adult women and 11 to 34% of men, increasing with age and comorbidities. Despite its prevalence, many patients never bring it up. So clinicians need to ask proactively, normalize the discussion, and identify reversible causes eliciting precipitating factors and identifying which type of urinary incontinence is most likely, which can help with management and decrease possible consequences related to this incontinence. Urinary incontinence or loss of bladder control can range from occasional leaking to the inability to control urination at all. Various factors such as age, pregnancy, childbirth, and childbirth trauma, or certain medical conditions can contribute. There are different types of urinary incontinence: stress incontinence, urge incontinence, and overflow incontinence are a few. Treatment may include lifestyle changes, pelvic floor exercises, medications, or surgery. To add context to this lecture, we will be discussing a case of an 84-year-old female who comes in with a history of uterine prolapse and intermittent incontinence. She has to push the uterus up to empty her bladder completely. She has some urgency and has at times not made it to the toilet before getting wet. She has no dysuria or hematuria. She does have nocturia X2 and urinary frequency. She has not had a UTI recently, but does worry about having an accident in public. She comes into your office for an annual wellness exam, and when asked if she had any concerns, she shared that she has intermittent loss of control and does not want to wear incontinent pads or briefs. She does enjoy being active in her community and wants to be able to comfortably go out in public. She worries that when she laughs or coughs or sneezes, she might lose her urinary control. There are different types of urinary incontinence. Stress incontinence, or leakage during physical activity, happens when you exert pressure on your bladder by coughing, sneezing, laughing, or physical exertion, like lifting a heavy object or straining in any way. The mechanism is urethral hypermobility, or intrinsic sphincter deficiency, resulting in leakage with increased abdominal pressure. It is common in women post-childbirth and in patients with pelvic floor weakness. Urge incontinence usually results from detrusor overactivity. This can be idiopathic or neurogenic. When this happens, what results is an intense urge to urinate. They may need to urinate often, including during the night. Urgency can come from minor conditions, such as an infection or neurologic disorders or diabetes. Often, this is part of an overactive bladder or OAB. Overflow incontinence usually is manifest as frequent or constant dribbling from the bladder that does not empty completely. It can be the result of a neurologic deficit that prevents normal detrusor function, and as the bladder enlarges, the increased pressure overcomes the tone of the lower urinary sphincter and constant dribbling of urine can occur. Also, urinary retention can occur, with some patients unable to empty their bladder. Functional incontinence can come from a mental or physical impairment that keeps you from making it to the toilet in time. An example might be when a patient with severe arthritis cannot get their pants unbuckled fast enough. Mixed incontinence patients experience more than one type of incontinence. Usually this is a combination of stress incontinence and urge incontinence. In some cases of transient incontinence, the DIAPPR mnemonic is helpful: delirium, infection, atrophic changes, pharmaceuticals, psychological, excess urine output, restricted mobility, stool impaction are all potential causes. Many things can precipitate an increase in incontinence. These usually causes a temporary incontinence. This can come from increasing urinary volume or stimulating bladder contraction. Things ingested in your diet, such as alcohol or caffeine, carbonated beverages, artificial sweeteners, chocolate, chili peppers, spices, foods high in sugar or acid, such as citrus fruits, can contribute. Medications can precipitate increased incontinence. Diuretics or alpha blockers, diabetes medications like SGLT2 inhibitors, sedatives such as benzodiazepines or narcotics, and muscle relaxants, to name a few. Take a good history, including asking about voiding patterns, nocturia, triggers, pad use, fluid intake, and medications, diuretics, anticholinergics, SGLT2 inhibitors. Physical exam should include an abdomen and pelvic exam in women looking for prolapse and atrophy, a digital rectal exam in men to evaluate prostate size, and a focused neurologic exam. Workup should include a urinalysis checking for a UTI, looking for evidence of hematuria and/or glucosuria. A post-void residual, or PVR, is helpful in a suspected urinary retention or an overflow incontinence. Validated questionnaires, for example, ICIQUI, OABQ, can help quantify burden. Urodynamics are reserved for complex cases, such as refractory symptoms, neurologic disease, or prior pelvic surgery. A stepwise approach, using the least invasive first, is the model that is recommended by major societies. First line would be lifestyle and behavioral. This would include weight loss. Modest reductions improve symptoms of urinary incontinence. Reducing bladder irritants, such as caffeine, carbonated beverages. Using timed voiding or bladder training, effective in urge urinary incontinence. And smoking cessation, as well as controlling constipation. Pelvic floor muscle therapy, or PFMT, has strong evidence of benefit, especially in stress urinary incontinence, according to the AUA and Cochrane reviews. Referral to pelvic floor physical therapy improves adherence and technique. For urge incontinence, some medications may be helpful. Antimuscarinics, such as oxybutynin, sulfonylurea, tolterodine, can be helpful. Watch for cognitive side effects in older adults. B3 agonists, such as mirabegron or Vigron, can be better tolerated and are useful in older patients or those at cognitive risk. Lastly, some patients may not receive adequate improvement with these interventions and may need to see a urogynecologist to consider procedural intervention. This 84-year-old female has signs and symptoms consistent with a mixed incontinence, stress, and urge incontinence. She was given options of hysterectomy and cystosal repair with urethral sling versus pessary and follow-up, and to consider medication if not helpful. She chose to start a pessary. She had initial fair results, less incontinence, and could get by with a pad. She was happy with the initial response and was willing to follow up over time. She was able to do what matters most, remaining more active socially. In summary, there are different types of urinary incontinence, and determining the type helps in management. Taking a good history is important. Stress, urge, overflow, functional, and mixed urinary incontinence do occur, and treatment options depend on the type and cause of the incontinence. There are dietary choices and medications that can affect continence. Looking for and asking about these will help us eliminate things that may contribute to worsening incontinence. Interventions should start with the least invasive measures first and progress if incontinence is not adequately controlled. Acute urinary tract infection can lead to acute incontinence. Looking for and treating it will improve outcomes with any change in continence. Here are some references. Thank you for your time and attention today.